Okay, I guess I'm gonna start. Hi everyone. My name is Erin McKinney Prupis. Can someone do one of those handshaking so I know that you can hear me?
We can hear you.
You can hear me. Okay, great. Libby, are you gonna introduce or should I start?
I'm happy to introduce. Hi, everyone. This is Tailoring the Client-Focused Considering Work Model to an HIV Peer Program with Erin McKinney Prupis, the Assistant Director of Alliance for Positive Change in New York. So welcome, Erin. We're really looking forward to your presentation.
Thank you, Libby. Okay, so first off, these are very, very difficult times, and just wanted to say I appreciate everyone who's here, appreciate you've turned off your TV, and hopefully we could take a break for the next 55 minutes and think about what we do in our everyday life as working with peers. So as Libby stated, I'm the Assistant Director at Alliance for Positive Change. We are a CBO in Midtown Manhattan, and we're in New York City. I'm also a current doctoral student at the City University of New York School of Public Health. This presentation has come from a piece of my dissertation work. So what we're gonna, for the past 5 years, I've been the program evaluator for our HIV peer program. And this presentation is gonna be based off the lessons that I've learned as the evaluator, a 2016 focus group study completed for my dissertation, Goldblum and Kohlenberg's client-focused considering work model, and other literature on employment and workforce development for people living with HIV. This presentation will be looking at the vocational counseling model and tailoring it to a peer program. I will be describing the client-focused considering work model for episodic and emerging disabilities. I'm going to discuss the strengths and limitations of the models as it applies to peers, and we'll share the tailored model that I produced for our HIV peer program. Additionally, I'm going to describe some of our peer program services and tools that align with the model, helping peers to move through different stages of considering work. And lastly, I will provide suggestions on how to evaluate peer programs based on the tailored model. For some reason, I don't know what happened to my chats. Maybe it's because I'm sharing my screen. So I will stop at different points to ask for questions, but for now, just so you know, I cannot see the chat.
So Erin, I will try to keep an eye on the chat for you because while you're sharing your screen, you can't see it at the same time.
Okay,
yeah.
All right, thank you. Okay, so this is the client considering work model for episodic and emerging disabilities. This model was originally designed by Goldblum and Kohlenberg in 2005 to help guide vocational counseling for people living with HIV. This time period was a turning point for many people living with HIV. In the first 2 decades of the epidemic, people living with HIV had many barriers to work directly related to their HIV treatment and the disease itself. In the early 2000s, HIV drugs became less toxic and more effective, and many people began to consider entering the workforce. Vocational rehab centers weren't really ready for people living with HIV. They didn't really understand the concerns that people living with HIV had, and they definitely were not utilizing services. They had rates of like 10 times less utilization of vocational rehab centers compared to people with other types of disabilities. So this model was very transformative and important to help guide work done with people living with HIV. In 2018, the model was revised by Liza Conyers, a professor at Penn State, to apply it to other emerging and episodic conditions where people are often reliant on public benefits, such as people with substance use and mental health concerns. So although this presentation will focus on people living with HIV, it definitely is relevant to peers with other types of conditions. The model applies 3 intertwining concepts: the client-focused approach, domains of influence, and stages of change. This slide displays a pictorial of the model that Liza Conyers developed, and I will discuss each of the concepts as it applies to the model. As many of you know, being a peer is very transformative for the peers, and it's an intervention in and of itself. Proving the impact of a peer program is often challenging because peer programs are typically they're often homegrown and not necessarily always based in theory, definitely in evidence-based practices, but still hard to evaluate. And this model provides some guidance on how to evaluate peer programs. People with episodic disabilities, especially those with HIV, are often relying on public benefits. So transitioning to full-time work is a major decision for these individuals. And for some, it's not the best decision. It's not what's going to give them the best economic prospects. What's great about this model is it is client-focused, and the transition to full-time is reliant on the peers themselves. It does not assume that full-time work is the path for everyone. So as you can see, this is this model is very similar to the stages of change theory, but there is not a pre-contemplation period because it's not assumed that not working is a problem. Okay, so the client-focused. The client-focused approach is based on the principles of self-determination, self-efficacy, and consumer-directed empowerment. In their model, Goldblum and Kohlenberg stated, the central premise of the client-focused approach is that the rights and responsibilities for making vocational choices, i.e. altering, entering, re-entering, or leaving work, including peer work, rest solely with the client. They describe self-efficacy as a self-perception of one's capability, effectiveness, strength, or power to attain desired results, and the consumer-directed theory of empowerment as a process in which one defines and achieves goals based on a foundation of knowing and valuing oneself. Although Goldblum and Kohlenberg mentioned these concepts as critical parts of their model, they did not choose to display it in their model, which you can see. This is their original model. The one I showed you earlier was a revision of it. The domains of influence. So throughout the process of considering full-time work, individuals need to weigh the pros and the cons and work through the domains of influence. The various domains of influence are the medical, psychosocial, vocational concerns, vocational competence, and financial/legal. The domains are embedded in the vocational research regarding the motivators of and barriers to work for people living with HIV. And individuals who are contemplating a change in their work often consider each of those domains to increase their ability to make well-informed decisions that maximize individual outcomes and minimize the undesirable costs. Individuals weigh the elements of each domain because work choices can both enhance and hinder personal outcomes. For example, returning to work may have positive psychosocial results because they make friends and they build relationships with supervisors and the fellow peers, and it feels good to help other people, but negative health consequences. It may get in the way of them being able to attend doctor appointments, or may make them not. Some people may be more challenged with taking their medications. So there's always, we have to kind of judge. So I'm going to go through each of the domains. The medical domain incorporates various health concerns. How do the peers currently feel health-wise? How prevalent is an episodic disability? And I know I keep mentioning that I haven't defined that. So episodic disabilities are when someone has some kind of condition, health condition, and they don't always, they don't always feel the consequences of the condition, that it can come on suddenly, last for a few days to a few weeks, and then it's gone. And this may only happen a few times a year, or maybe even a few times every few years. So as you can see, this is very prevalent in HIV, but also prevalent in other types of conditions, which is what makes it challenging with work, because we find that peers would love they think they're capable of working full time, but they just have this, we call it the health fear, this fear that something's going to go wrong, and then what will happen? How will I get back on benefits? How will I be taken care of if I all of a sudden have to stop working full time? The medical domain also incorporates things like medication adherence, medication side effects, how often doctor visits are required, and the impact of stress on work and their health. The medical domain often intersects with the vocational concerns domain. Vocational concerns relate to external factors, such as the labor market trends, a pandemic happening, work policies, sick time, break times, vacation times, discrimination, physical demands of work, and the number of work hours. Vocational competence refers to kind of their internal characteristics, such as their vocational skills and abilities, their ability to write a resume, to go on interviews, to look for jobs. The financial legal domain includes earnings and benefits and the policies surrounding benefits. For many people living with HIV and lots of people on disability, losing their benefits is often the largest barrier to full-time work for them. Lastly, the psychosocial domain involves the current psychological needs of the peer, as well as the psychological and social impacts of work. The next slide will display the complexities of decision-making for peers, and this is really specific to New York City when deciding to move from benefits to work. This is something that came directly from my work in my dissertation, and I just thought it was important to show, because making these decisions is very complicated. There's a lot of different pieces that they have to consider, and so I just kind of wanted to show the kind of complexity, how things intertwine with each other. So this is, and just to go back, like, making these decisions is definitely not an easy process, especially for peers with limited work experience, especially work experience outside of being a peer. So this is the phases, now we're going to pay attention to the phases of work and talk about the different stages. It's similar to Prochaska and to Clementi stages of change, modeled to explain the stages of addiction and recovery. The 4 phases of considering work include contemplation, preparation, action, and resolution. Stage-related decisions and activities are needed in order to effectively gauge the risks and benefits of making an employment change. So to go through each of the stages. In contemplation, this is when peers are thinking about, am I ready for full-time work? And this can occur because they have some kind of internal or external pressure for a life change impacting one or more of the domains of influence. They may want more income. They may feel healthy enough to work, or new legislation may occur forcing them to consider change. During this stage, individuals are asking themselves, is any change feasible? And they consider the risks and benefits of change for each of the 4 domains. And this process can also happen when someone is going through a peer training and then thinking about also part-time peer work. During the preparation stage, peers are asking themselves, what kind of change is best? The activities at this stage, as you can see, are broken into 2 different parts. Part A focuses on setting goals and setting vocational goals and making a plan. And part B focuses on the implementation of intermediary goals needed before someone is ready to start searching for employment. And this can be things as vocational training, education, vocational evaluation, or for many, participating in a peer program. During the action phase, individuals engage in steps towards paid employment, such as applying for jobs and going on interviews. And lastly, in the resolution stage, individuals ask themselves, is the pressure to change, has it been resolved? They either choose this need in a non-work way, volunteer, find a roommate, etc., or they have chosen to work and are now adapting to their new circumstances. Or they may choose that doing part-time paid peer work is the best solution for them. Goldblum and Kohlenberg stress that this is a non-linear process, and at any time persons can reconsider and move on to a new stage or back to a previous one to help with their decision making. And it's really important for peer supervisors to help provide these different vocational resources and to make sure that the resources that they're helping them with are specific to the stage related concerns. So I'm going to take a break here. The next thing I will be discussing is my specific peer program that I work with and our different tools that apply to this model. But I'm going to open it up for any questions that people may have about the model. I'm going to stop my share so maybe I can see the chat.
Okay, so the measures we looked at, I'll try and go through these briefly. We have peer supportive organizational climate, which is, well, that was done.
Hello? Okay, I'm not sure what that was. And yes, I can definitely email the presentation to everyone. Okay, so I'm gonna go back to sharing if no one has any questions. Okay, so I'm going to talk about our program. So Alliance for Positive Change helps New Yorkers affected by HIV and other chronic illnesses to make lasting positive changes towards health, housing, recovery, and self-sufficiency. Each year, we help New Yorkers get tested for HIV, overcome addiction, access medical care, escape homelessness, rejoin the world of work, replace isolation with community, and lead healthier lives and more sufficient lives. Peers are a critical piece to our program. They are a part of each of our departments, and we employ 140 to 150 peers at any given time. So we do have quite a large peer program. This is just looking at some of the things that we help people with. We help people with housing, mental health diagnoses, food insecurity, entitlements. A large portion of our participants are living with HIV, 55%, but even larger percentage have mental health concerns. Over half are dealing with some kind of chemical dependency history, etc. So peer training at the Alliance. And since 1992, we have been designing and delivering innovative peer education and training programs that create economic, social, and health relating building blocks to empower peer trainees to take control of their lives by improving their health, sustaining long-term recovery from substance use, and developing marketing skills. Alliance's peer trainings and peer delivered services are conducted by multilingual staff and peer educators who reflect the target population in terms of cultural, social, and experimental backgrounds. So I don't know how familiar people are with HIV peer programs. They are different than substance use peer programs and different from people with mental health. It's a lot more recent that HIV peer programs have been recognized by Medicaid to be kind of peer delivered services. We don't have the same kinds of things in place, I think, as they do in substance use and in mental health. HIV peer programs are a lot more kind of homegrown, and they could differ widely state by state. It's just started recently for states to have HIV peer certifications. And I'm in New York, and there's just a few other states, I think under 10 states who have HIV peer certification programs. So we're not as, I don't think peer programs for HIV are as standardized as other programs are. Our training is, we do something, it's called PrEP. It happens every 6 months. Usually we have classes of 30 to 40. It's 8 weeks long, 3 days a week, 7 hours a day. And we have a focus on teaching them about health and chronic conditions and substance use and recovery and harm reduction. And we also, the biggest focus is kind of helping our peers with soft skills. You know, I would say 1/3 of the people in each class don't have a high school degree. 50% of them have never worked, or they haven't worked in over 10 years. Hardly any of them have ever worked in kind of an office environment. Most of their work experience has been in jobs at minimum wage. So there's a kind of a big, and they haven't been in school for a really long time. So a big purpose of our training program is to kind of help them to be able to manage themselves in an office environment and manage themselves in a classroom. One of the biggest impacts of the program is the relationships that they build with each other. In HIV, especially in communities of color, it can be, you know, having HIV there's still a lot of stigma. And we find that a lot of our peers they come from places of isolation where they have to hide their disease status. And it's very stigmatizing. So our training program it's very beneficial for people, and it has had huge impacts, huge psychosocial impacts for the peers. From our training program, we hire usually 5 to 10 people from each class to join our program. And so what we started in 2013, it's called Peer Training Inc., which is our peer, it's to provide peer certification training and paid peer placements at medical and social services agencies. We are a New York State Department of Health certified training center for both foundational and peer certification trainings. And we're also an OASIS authorized training center for recovery coach. Peer Power is a programming model that drives economic development and social impact through role modeling. Peers empower individuals to become community leaders, and they inspire others to make healthy choices. You guys can see this is a picture of graduation. So at the end of we have 2 different major trainings. We have the foundational, it's called the foundational training in HIV, which was the original peer training program I was talking about. And then we have our peer certification New York State training. And so at the end of each of these trainings, we do major graduations for our participants, because many of our participants never graduated high school, definitely have not graduated college. This is a very meaningful experience for them. And we're thankful right now that we finished our last group a few months ago. So they luckily were able to get a graduation. So our peers, like I'm sure many of you, have shared lived experiences with the people that we serve, culturally, linguistically, and socially. They help to reduce barriers to care because they understand they are living with HIV, or they have the chronic conditions that our clients do, and so they understand the systems and can help people work through the systems. It's a great way to foster trust, promote long-term engagement, and guide patients toward health and stability. These are some of the things that they do: outreach for patient activation, linking people to care who have been out of care. That's especially relevant for people living with HIV. So we find people who haven't been to the doctor in over 6 months to try to engage them back into care. We do patient navigation, taking people to the doctor, appointment reminders, accompaniment of services. We provide coaching and health education, motivational interviewing and goal setting, self-management and adherence support, case conferencing. We also have a number of different support groups that our peers often run. And we do a lot in all of our trainings that we do have staff that are involved, but the peers, we have like senior level peers who are the ones who do all the different trainings that we offer at the agency. So this is our peer model of our peer program. Again, we have 140 to 150 peers, so it's a large program. And so we've had to come up with a number of different things to make it work. So, you know, first everyone has to be part of some kind of foundational training to be a peer. In New York, the peer certification has only been around for 4 years. So as of now, that's not a requirement for people to join our internship program, but people usually obtain it while they are a peer. So the different things that we do for our peers is we have, and I'm going to talk about each of these things, is we have a mentorship program. Peers participate in support groups. People are allowed to go twice a month to different advanced trainings, to peer certification, OASIS, recovery coach trainings, or other kind of things that are related to the job that they have. And then we also our mentors do peer development plans. And lastly, we have vocational preparedness support services available on site. And I guess the way that our program works, it's in 6-month cycles. Peers work 15 to 20 hours a week, and their hours often depend on the type of benefits that they receive. The peers who work 15 hours receive a $500 stipend, and our peers who work 20 hours receive a $1,300 stipend. And this is based off of the benefits they receive and kind of the laws about how what they earn will impact the benefits. So all of our peers do receive some form of public assistance. 90% receive some kind of direct cash assistance. In New York City, we have something called HASA benefits. And HASA benefits provide people living with HIV with certain eligibility requirements. Medicaid, it gives them their Medicaid, food stamps, housing, and their cashing assistance. And HASA anyone living with HIV at a certain income level, it doesn't matter what their health is eligible for those services. So in New York, we are very lucky. We do have a law that when people work as a peer, any income that they earn as a peer is exempt from the calculations of their benefits. So that's really great. So those peers are able to earn the $1,300. 45% of our peers receive Social Security, so that is a bit more limiting on how much they can earn before it really impacts their benefits. And so those peers typically they're the ones who will work 15 hours and earn the $500. And that amount was decided with the collaboration of the peers to see what was best for them. Okay, so now to kind of tie in together the model, the client-focused considering work model with peer programs. So it is a great model, and there's a lot to work from. And I'm sure a lot of you, when learning about it, you were realizing how much, if you were a former peer or if you are a peer, how much that process really applied to you, and understanding how much that really does apply to your peers. But it doesn't necessarily address the unique challenges of peers. Now, I work with HIV positive peers, so that's the community I know the best. And with my peers, our peers often have really long histories of trauma and abuse and of problematics of substance use. A lot of them don't have a high school degree. They definitely don't have a college degree. They've never been asked anything like, where do you want to be in 5 years? So for many of them, peer work is their first real job. And so that model, a lot of it seems to apply to someone with work experience who, because of their disability or their chronic condition, had to stop and now they're going to be ready to re-enter. But that's not really the situation, I think, for many of our peers. And I think what's really missing from this model is something that addresses what a peer program needs to do to really address the fact that they are coming from places of trauma. And so I'm in a minute, I'll show you that those are some of the changes that I've made to the model to make it more appropriate for peer programs. And then the other piece to it is that it does give a really great global perspective for people when considering work, but it really doesn't provide specific systems that programs can utilize to implement and duplicate the program. So this is the model that I have created, that I tailored from the original model to help guide other peer programs. So at the top of the model, what I added was a supportive and empathetic environment that contributes to self-esteem and growth. So recognizing that there needs to be certain staffing in place so that peers have a support system, and that the first time they show up late to work, or they don't call in when they're sick, that they're just not going to get fired, that there's systems in place to help with their growth and their development. Then I listed the stages of change are in there. And then I also added about the domains of influence. I think like the domains of influence are really are complicated for people. And what's great about participating in a peer program is that it allows you to kind of learn about the domains of influence and then experience changes with the domains of influence as you are experimenting with work. And that is kind of done through different program tools to help enhance the self-efficacy and job readiness for our peers. So I added that middle piece to the piece on the left to kind of put more of a focus on that, and to realize that these things don't just automatically happen, and that you need to have systems in place to help facilitate peers to consider the domains of influence, and you need support to move through those stages, through your phases of work. And I will say, so our agency peers typically, we hire people for a 6-month period, but our peers typically say 2 years. We have many peers who've been with the agency for 20 years. So it changes. And often how long they're with us, it depends on where they are with if work is ever going to be a possibility or not. But it does differ. And the way, how peers utilize this model differs depending on where they're at. So I'm going to now talk about, and I'll take a break right now if you guys have any questions. Okay. All right. So our peers employed full-time. So our peers are employed, as I stated, but it is part-time work. If they work full-time, then they wouldn't be able, the different things with benefits wouldn't apply. So, so they're no longer, once they become staff, they're no longer considered a peer. And we do, 25% of our staff were once peers. How is stigma among non-HIV positive peers with HIV positive peers? What are their barriers? Are there preferences in hiring non-HIV or HIV positive peers? Okay, so we do, about 80% of our peers are living with HIV and 20% are not. Our agency primarily serves people living with HIV. So, and right now, the way things are moving is people are going to be required to get the peers, to have some kind of peer certification. So we have kind of increased the number of people living with HIV as peers due to that reason, because we know that's how we're going to get funded future, is that, we're going to have more and more grants and Medicaid that's going to require people to have a certification. So, but for our major certification is the HIV certification, which has, you could also, there's different pieces. could be living with HIV, you could be living with, you could be once had Hep C, and or experience with harm reduction services, so someone who once utilized needles. So and there are definitely differences that I have found with and stigmas related to people living with HIV and people who are not, that have been problematic. I will say that that's definitely an issue we've had to address. And it's the stigma is, they of course, you know, I never realized it was such a problem until I recently did some focus groups with our negative, our negative peers about utilizing PrEP, which is the drug to help prevent HIV. And that's really when I saw stigmas that they were holding, and how they were talking about how they would never have a partner with HIV, with someone who's living with HIV. And so I did bring those kinds of concerns to the people who work more with who run our support groups and stuff with our peers, to kind of address these different issues. But it definitely is there. But it's there for some people, but definitely not for all. A lot of our peers they have spouses who are positive, or they lost a brother or a mother, or, you know, people, they come to our program because HIV has impacted their lives somehow. Okay, any other questions? Okay, so I will go back to the presentation.
I have a question for you, Erin.
Yes.
I'm wondering if you feel that the stigma towards HIV has changed over the years.
It definitely has changed over the years. And I think that, well, I mean, it depends on the population. I think I think that in their communities, in the communities where our peers are coming from, which are, I think there is still a lot of stigma. And I would say that just because of the amount of isolation that our peers experience before they join our program, and the level that they feel like they need to hide who they are and what they're doing. And we still see it a lot in like our outreach work, and the people that we are trying to find who have been lost to care. One of the #1 reasons that they are lost to care is just because they're not open about their disease, and they do try to hide it, and they feel like they're being stigmatized. So is it changing? I think the fact that we now know that, you know, people on their medications, they're completely undetectable and they can't pass it to anybody. I think that's really, really important messaging. And I think that has had a large impact on people. But, you know, I still think there's issues like people don't necessarily want to date someone with HIV if they don't have it. I can't say that that's disappearing. I don't think that people experience things like discrimination in the workplace, or you know, they don't experience things where you're not going to hug someone with HIV. I don't think those are necessarily things. And also I think when it comes to the stigma, it's not necessarily about the HIV, but it may be more about someone being gay, or, you know, someone, you know, if a woman, you know, people finding out that the person, you know, calling them that they're slut, and kind of the slut shaming that goes there, or finding out that they had partners that were maybe drug users, or if they were drug users. So it's more about, I think the stigma is often more about how they maybe acquired HIV than it necessarily is about HIV.
Thank you. That's helpful.
And we do find, you know, another part of my dissertation research was looking at the psychosocial impacts of participating in the training program and being a peer. And one of the things that I looked at was internalized stigma. And we did find there was major changes, major decrease in the amount of internalized stigma that people felt by participating in the program. Okay.
That is so cool.
Yes, that was a really great finding, that we're able to statistically prove. It was something that we had, you know, heard from focus groups and learning from other people, But yeah, so it isn't, because, you know, before they become a peer, they don't, you know, they kind of hide their status, and now they're willing to make videos and go on Facebook and be a voice of the agency, something they wouldn't have been able to do before they started with the program. Is the goal to funnel PL navigators into staff roles for your nonprofit, and how many of your peers are interested in working in the nonprofit world? So it is definitely one of our goals to it is definitely one of our goals for peer navigators to become staff members. But I wouldn't say it's necessarily a large percentage of people who are looking at any given moment, looking for full-time employment. Becoming a staff member is not a goal of 6 months from now. It's maybe a goal of 2 years from now or 5 years from now. So it's something that they are interested in eventually, but it's often not the immediate goal. What we find with our peers is usually they're going to do one cycle and they're going to become a staff member, or maybe they'll do 5 years until they're going to be ready to become a staff member. I think that in New York City, we are very lucky to have our HASA benefits. I think it's amazing for people living with HIV, and it's an excellent support system. And what we find is that basically with their HASA benefits, which means they get free housing, they get Medicaid, they get food stamps, and then they get additional, like an additional $200 a month of additional cash assistance. And if they're earning the $1,300 a peer, like what we've calculated is that's the equivalency of making like $50,000 to $60,000 a year. And starting salary for a staff member is going to be between 35 and 42. So making that transition, if you're someone who's on HASA from peer to staff, that is a really big decision, because it will take time until you will have that kind of income equivalency. So that is a barrier. I mean, in a lot of ways, I think this is, that's why I think having the peer position, yes, it's called HASA. It's the AIDS, I don't know, we just call it HASA. I never can remember what HASA stands for. You can Google it, but it's like it's just the services that were set up in New York because we were at the start of the epidemic back in the 80s, and these systems were put in play to make sure that people had housing. That was really like the original function, was just to make sure that people living with HIV had housing, which is really so critical. Because, you know, as you guys, if someone doesn't have housing, they're not going to take care of their medical needs. And so it is something that we provide to anyone with HIV. It used to not, it's now called HASA for All, but that is new in New York City. I think it's only been the past 4 years or so that we've had HASA for All. But, you know, I think when I started my dissertation journey, it was very different then than where I am now. And really what I've realized now is that having a peer program is amazing, because you know, there's you know, when you think about part-time work versus full-time work, for people living with HIV who maybe have mental health concerns, who have substance use histories, you know, they're going to their 12-step meetings. They are going to they're going to meet with mental health professionals. There may be parts of different support groups, and they're working. And they have a lot of, you know, they do have a lot of other chronic conditions, a lot of doctor's appointments. So being able to manage full-time work with all of those other needs can be really hard. And so doing the part-time work is kind of the perfect thing for them. And they've also really reported that they don't think that they would be able to provide the same level of care to their clients if they were working full-time. They feel that doing it part-time, it's less stressful, and they're just able to give more. And, you know, they've said to me that they don't think they would be able to give the same kind of experience to their clients. So I think it's really important, and it gives them an opportunity to be at an economic level that they just wouldn't be able to be unless they actually have a college degree in New York City. So, you know, it is complicated, and we definitely do want to get people to full-time employment, but we definitely are well aware that it's not the best situation for all people. You really have to, there's other considerations that are really important. A big one being how big their household is. So for 2-family households, sometimes employment can be a better option for people. But if they're a 1-person household, I think it's not always the best situation. And then obviously health does have a big piece in it. We find that peers that come to us in their 20s and 30s and early 40s typically are more wanting to work full time than people who come in their later 40s, 50s, and 60s. And a big percent, it's like 60% of our peers are over 45. So a lot of them do come older, and they have and it's not necessarily the HIV that is their health concern, but it is other chronic conditions that they're living with that would impede with them being able to work full time. That was a long answer for a short question. Okay, so let's go back to the presentation. Share screen. Okay, so the tools that we use at our program is our mentorship program, which is, I think, it's the most pinnacle and important piece of our program. And as I stated before, our clients have really experienced multiple traumas. They often enter the peer program feeling depressed, isolated, lost, feelings of worthlessness. And most of our participants do not start their peer internship with self-efficacy or self-esteem or the knowledge to change their vocational directions, all things that are important pieces of the model. And so we have found that lots of our services are there to really build up the peer and make them ready to make changes. And we're not just talking about making changes for their professional development, but also their personal development, health development, mental health development. But our biggest program is our mentorship program that really helps with that. At the Alliance, each peer is assigned to a mentor. Often the mentor works in the same department as the peer, and they also function as their supervisor. The mentorship impact, it varies how it's impacting them depending on where I think the phase the client is in. The mentor formally meets with the peer twice a month for coaching and supervision. The mentor and peer create a development plan, which I'll talk about in a minute. The mentor fills out quarterly evaluations that largely focus on the peer's ability to meet certain soft skills, such as dressing appropriately, asking for help when needed, and working as a team. All mentors attend a mentorship orientation each cycle and attend a mentor's monthly meeting where they get skills training and support. The skills training involves topics such as conflict and resolution, dealing with counter-transference, and supervision skills. Mentors also have access to a staff member to help them through any struggles they may be facing in working with the peers. We really find that having a mentor program keeps our program client focused. It provides the peers with a supportive role model. Over 1/3 of all mentors were once peers themselves. They help peers during that transition to work. Mentors recognize that being a peer is not only about learning how to work with clients, but also how to maintain an office job. They help them manage office politics, help them with appropriate dress and communication skills. Peers report that the mentorship program is a vital part of their process. The support of mentors helps peers to really rebuild themselves. One peer stated is, "What I learned here with Gina is that we all fall, and it's how you get back up. And had it not been for them embracing me and not making me feel as bad as I honestly felt when I got here." That's what this agency did for me. Mentors help the peers address some of the domains of influence, specifically health, vocational competence, and the psychosocial domains, and they help them move through the different phases of work. Their mentorship helps them to recognize what is their potential for growth and their ability for more advanced work. The evaluations that the mentors do with the peers help them to understand their strengths and their weaknesses. As one peer put it, the evaluation helps you see where you're at and where you're going or what you can improve on. It makes you see my progress. Watching score changes throughout a cycle is an empowering and insightful experience for many of our peers. It often helps them to assess if they're ready or not to handle a full-time job. Having an effective mentorship program is very challenging. It's a lot more work than just assigning a mentor to someone. We've learned that there needs to be multiple staff trained in trauma-informed care, responsible for managing the program. It's important that you have trained social workers or counselors as part of the peer mentorship program and part of the peer staff. You also need someone with the skills to lead the monthly training sessions and mechanisms to track that supervision is actually occurring. As I'm sure you guys know, there are wonderful peer mentors, and then there are peer mentors who need a little bit more work. So it is important to have tracking mechanisms in place to make sure they are providing the support that they're supposed to be providing for our peers. Our next major tool, and I will kind of rush now, I notice we're towards the end, is we have something, we call it our peer development plan. And the peer development plan is made with the peer and the mentor. This is something that's especially helpful during the preparation phase where people are deciding what are their vocational goals, because it helps the peers decide what kind of change is best. During this process, the peers and the mentors set goals and create plans to achieve them. The peer development plan was designed to help peers identify professional, health, and emotional wellness goals. Peers choose one long-term goal for each category and two short-term action steps, which is what we call them. Really, they're the same thing as SMART objectives to help accomplish these goals. Mentors help them to decipher the next steps to pursue long-term goals. They teach them how to make the SMART objectives that are specific, measurable, achievable, realistic, and time-bound. You know, and doing this process is an important piece in the Kohlenberg-Goldblum's model. Mentors meet monthly with their peers to assess how they are moving with their plan and help them to make adjustments as necessary. If they complete action steps, making new action steps. If they're really struggling with an action step, you know, rewriting it and making something that's more feasible. Peers find that creating these development plans is empowering, and it helps them to decide on their future vocational directions. They find that it's impactful. As one peer put it, "It made me participate more in what I wanted to do." So the process helps peers feel in control of their future, something they often felt they were not able to do of their paths. So the peer development plan is not limited to professional development, but also includes health and wellness goals. This allows for peers to pursue vocational goals while at the same time focusing on their physical and mental health, allowing them to experiment with how vocational change impacts their other domains of influence. And to go back to Goldblum and Kohlenberg's definitions of their concepts of what self-efficacy is, the self-perception of one's capability, effectiveness, strength, or power to attain desired results, and consumer-directed theory of empowerment, process in which one defines and achieves goals based on a foundation of knowing and valuing oneself. We don't feel that that's not where the peers are at when they enter our program, and through the process of peer mentorship and the peer development plan, these are skills that they now develop and they can move through these processes in a more effective way. You know, it can't be assumed that, especially that our peers have a foundation of knowing and valuing of themselves. They struggle with their self-esteem and their mental health. And they're really, our mentorship and peer development plan is really what keeps our program client focused. Our next thing is support group. I'm going to assume that that is probably something that many of you do, so I will skip over that piece. But our peers attend a support group with their peers led by a staff member who was once a peer 3 times a month. Then the last thing is that we've added, this is something that we've only added to our program in the last 3 years, and this is vocational services. So we have staff that are part of the program that help them with the domains of vocational concerns, vocational competence, and the financial legal. As I was saying, for people living with HIV, the biggest barrier to work is often the loss of benefits. So having someone to fully understand the laws surrounding benefits is really important. Peers often do not really understand how work will impact their benefits, and they definitely do not understand the various transition to work programs. So it really helps to have someone on staff who can guide them through that process. They're also there to help them build resumes, search for jobs, fill out job applications, and prepare them for interviews. These services are really critical in the action phase, and they can help them build their vocational competence, and they provide coaching services to overcome vocational concerns and to help them understand limitations. This is my last slide. We can go back to questions. Is, you know, I think what's great about this model is how it can be utilized for program evaluation. Evaluating peer programs is really difficult. And by utilizing a model, it does kind of give you more focus on being able to evaluate. And I'm sure, as most of you know, this is, you know, this is often imperative for a lot of our different funding streams to make sure that we have evaluation processes in place. And what's great about this model is that we know that not all peers, their goal is not full-time employment. A lot of them will not gain full-time employment. So this model kind of allows for that flexibility. And, you know, as we in New York, because the people have the long histories of unemployment, maybe low educational attainment, the different stigmas, that they would not be able to obtain full-time employment at a livable wage. So therefore, it really is important to be utilizing a model where the main focus isn't just, did they reach full-time employment? So through this model, you can, you know, look at, were they able to accomplish any of those intermediary steps? Were they able to do any kind of advanced trainings and other vocational things to help them along this process? At any of our agency, many peers maybe have not taken action towards full-time employment, but they have accomplished intermediary goals that help to raise their self-esteem and confidence. So you can do things that specifically measure changes that happen with the different domains of influence. I do work with some researchers at Hunter and Penn State who have developed some different measures that kind of assess where they are with their phases of work, which can be very useful when evaluating their program and assessing how the various tools have helped them work through the phases of work and assess change in their domains of influence. So, and just a little background, a little plug for our agency is that through our Peer Training Inc., we do train staff. We do a lot of staff trainings on specific peer services, especially our mentorship and peer program and our peer development plan. We also offer various different types of supervision trainings. And I do have resources over at Penn State and Hunter College if you're interested in learning about the different surveys that they use to assess with phases of work and domains of influence. So definitely that is my email address. Feel free to contact me if you have questions about any of those services that we could provide for your agency.
So Erin, I have a question for you.
Yes.
I was hoping that maybe you could, you know, as you're winding up your presentation, could you tell us something about what this work has meant for you personally? I know I could really hear your passion. I know this has been a big part of your life, and just wondering, like, what it's been like for you to be involved in this process and to serve the people that you and your whole team has been serving.
So I got involved. I lost my mother to HIV as a child. I was actually a peer educator myself when I was in high school, doing HIV peer education. And when I was in my doc program, one day I got an email asking, they were looking for an evaluator for their peer program. So that's how I got involved with my agency. And it was a life-changing experience for me. I don't look like many people who are living with HIV. So growing up, I didn't know really many people living with HIV. So this gave me an opportunity to get to know the peers, and it helped, it helped me personally in dealing with the loss of my mother. And it gives me an opportunity to give back and to be part of this process, even if I'm not necessarily what someone would call a peer for most people that we serve at our agency. But you know, I don't necessarily supervise peers, but I'm more an evaluator, so I have to kind of be a little bit of an outsider with some of the activities that I do. But I still get to work with, you know, when I'm doing different projects throughout the agency, I get to work with our peers. I help run the alum organization. So it's been extremely impactful for me personally, and just being able to develop the peer program in a way where I know that they're giving back. And I'm also often, they see me as their voice. So because I do evaluation activities for them, I learn about what their different concerns are and their different challenges are. You know, I was the person who designed our peer development plan and helped change different things that we do in support group based on feedback that I've gotten from them. So it's been very impactful and just a really great experience personally.
Well, thanks so much, Erin. I don't know if you have any final comments you want to make. We will be sharing information about the presentation with attendees and even those who didn't fill it out. And I would encourage you to fill out the evaluation of the conference. There's a link in the chat room if you would like. And Erin, thank you so much for your presentation. It was really fascinating. So it was great to hear from you, and I'm glad you could participate.
Thank you. Have a great rest of the conference.
Okay. All right. Thanks so much.
Thank you.
We will be reconvening in this space in 15 minutes, so you can hang out here. Our next presentation will be with Cheryl Gagne, who is talking about supervision and the peer workforce, the development of competencies for peer workers. So hope to see you in that session.